topic areas. We're going to be talking about Meaningful Use program and Meaningful Use overview. So just a little background on the Meaningful Use program. It was established as a part of the American Recovery and Reinvestment Act era, and its goal was to incentivize the expansion and the use of specific electronic health record technology in the healthcare industry to facilitate better communication between healthcare providers and patients, as well as provide mechanisms for improved community health standards and the ability to gain specific knowledge and efficiency in the healthcare sector. There is a program of incentive payments that began in 2011, and eligible professionals who are participating in the Meaningful Use program, they have a choice of participating under the compliance with the Medicare program administered by CMS, or as a Medicaid provider, which this program is administered on a state-by-state basis. And the program period for incentive payments is slightly different for those two programs. What is important, though, is that after 2015, eligible providers in the Medicare system, or who participate in the Medicare program, the period of incentivization ends, and it becomes a negative or a reduction in reimbursement for those who choose not to participate in the Meaningful Use program. Beginning in 2015, it could be as high as 1% of Medicare reimbursement, and over a period of years it could rise to approximately 5%. The Meaningful Use program has become tremendously popular and seems to have been broadly accepted. There are approximately 488,000 participants in the Meaningful Use program, the vast majority of them being eligible professionals, while hospitals and critical access hospitals are about 5,000. And over $25 billion in incentive payments have been paid since 2011. The Meaningful Use program is set up so that there are requirements for eligible providers to meet a series of objectives. And these objectives are for eligible providers to show that they are meaningfully using their electronic health record technology. And there was established in 2011 Stage 1 of Meaningful Use, which comprised of a total of 18 measures, 13 core measures, and a menu of 10 others, from which eligible providers would meet 5. Hospitals had similar requirements. And then beginning in this year, 2014, there was a requirement to meet Stage 2, which added some additional measures and core objectives. And also, it's a slightly a slightly different approach. One way to look at it is at stage 1, required eligible professionals and eligible hospitals to use electronic health record technology that had the capability to meet the appropriate measures. And stage 2 is a requirement that, in addition to using the appropriate certified electronic health record technology, that you have to be using the capabilities to produce appropriate measures, and also to show that you have put in place appropriate protections for electronic health records that you are maintaining on your information systems. So the mechanism by which a eligible provider or a eligible hospital shows that they are participating in the program and that they have adopted the appropriate meaningful use standards is that they provide an attestation, and the attestation is just a report, an affirmation, if you will, that you have conducted the appropriate measures and that you are maintaining the records that are required for participants in the Meaningful Use program, and that you file the attestation with the government over your signature under pains and penalties of perjury, and the government will make an incentive payment to your organization or to your to you as an individual provider. And the incentive payments are based on a schedule, and the amount falls over the period of the incentive program. One of the modifications to the Meaningful Use program occurred in the Affordable Care Act of 2010. There was a concern in Congress that there were overpayments being made to providers and hospitals, and that there wasn't sufficient mechanism to capture those overpayments. And so in the Affordable Care Act, there were specific provisions concerning how overpayments are dealt with. So there are specific provisions that if there is an overpayment, that an organization has to return those funds to the Secretary of Health and Human Services or the state Medicaid administrator. And it also provides for a time certain in which the payments must be returned, and also specifies that an overpayment is considered, if it is not paid by the 60-day deadline, is an obligation under the terms of the False Claims Act, which certainly ramps up the seriousness of the obligation if it's not repaid. An overpayment is not repaid in a timely manner. Another concern in participation in the program and in one's attentiveness to making truthful and complete statements in their attestations and other documentation submitted to CMS or the state Medicaid agency is the increasing enforcement attention being paid by federal law enforcement authorities and the Office of Inspector General. Just this past week, the OIG, the HHS OIG, in their annual work plan indicated for the second year in a row that it is auditing participants in the Meaningful Use program to assure that their attestations are accurate and appropriate. And this year, the OIG added specific language that it will be auditing through its regional OIG Office of Audit Service offices. It will be auditing providers and hospitals participating in the Meaningful Use program to assure that they are completing the security risk analysis objective that is a part of the Meaningful Use program. There are also attention being paid to fraudulent activities for those who are making attestations that are knowingly false. In February 2014, we saw that a CFO with a now defunct hospital center was indicted by a federal grand jury for healthcare fraud by knowingly making false statements to CMS regarding attestation in participation in the Meaningful Use program to obtain over $1 million. And at the time, the SAIC for the Dallas regional office of the OIG essentially put us on notice. Anytime there is a government program that spends $25 to $26 billion, there is going to be attention paid to be on guard that the government's money is being spent wisely. CMS has created a system of audits for those who are participating in the Meaningful Use program. They have indicated that CMS will be auditing approximately 5% of all organizations who are attesting in any given year. And so, once again, these are for participants who are in the Medicare Meaningful Use program. States who administer the Medicaid Meaningful Use program are also engaging in audit programs, and they're being performed on a state-by-state basis. CMS has contracted with Figliosi and Company to conduct their Meaningful Use audits. The approach that Figliosi is using in their Meaningful Use program audit is they notify by letter, and the letter is sent to the official at a hospital or the eligible provider, and creates and provides a request for documentation that is in relation to the attestation for Meaningful Use. These audits are not begun by telephone calls, and they are not begun through an email message. For those who are concerned about being spoofed or false contacts, all of these are begun through the receipt of a letter that has CMS insignia on the letter, and that is how each engagement is begun. Once you've received the letter, the provider or the hospital has 10 business days, or essentially 2 calendar weeks, to provide through an electronic submission the documentation that has been requested. we urge you to provide the appropriate documentation that's requested, but don't oversend. Don't send documentation that's not being requested, as that will complicate or confuse the review of the audit documentation. The process that they're following is essentially the GAP process, or the government audit standards, and the auditor is reviewing the documentation against a protocol that they've established, and that they are assessing the documentation to determine if any additional information is needed. If additional documentation is required, they will send a follow-up request. It's usually sent in writing by letter. And if the documentation that they've received by Figliozzi and Company is determined to be insufficient, they will provide notice that the documentation is not sufficient, or that other data anomalies exist, and the organization will be notified to prepare for an on-site audit. The primary process or protocol and measures of the documentation to support the attestation in the audit is Figliozzi is looking at the source of the documentation that was utilized during the attestation process. They are assessing or evaluating the reports for measures that are produced by the certified electronic health record technology, and screenshots that are taken through use of the technology and submitted as a part of the audit documentation. They are specifically looking at the security risk analysis that is one of the core measures that supports meaningful use. And they're also looking for evidence to support that the source of the information was generated or created through the certified electronic health record technology of that specific provider or that hospital that is attesting to meaningful use. In addition, they are evaluating the documentation to determine that the evidence was created during the time period that the report covers, and that the documentation supports the methodology chosen for achieving the specific measures. For example, hospitals have a choice of determining their denominator through services observation encounters through their emergency department, or the other category would be a denominator of all emergency department visits. Another key component of the audit documentation is a copy of the certification for the EHR that is created or on file with the HHS Office of the National Coordinator, or ONC. The ONC has a website through health, and the information is provided as a part of your audit request, but you can go to healthit.gov, and under the tab for certification, you can create a certificate for your specific CEHRT technology to assure that it is certified for either stage 1 or stage 2. In addition, the reporting logic is also would also be sent in as a part of the documentation that is sent. If your organization is selected for an on-site audit, the auditors have a specific protocol for use in their on-site audits, and depending on whether your audit is based on for compliance or attestation for stage 1 or stage 2, the audit will be looking for different types of demonstrable compliance. Remembering that stage 1 is a measurement of the capability of the CEHRT, of the technology itself, and stage 2 is a demonstration of the ability to use the technology to meet certain requirements. So the auditor will conduct a structured walkthrough requiring specific demonstration that data can be drawn from the technology or through the EHR, as well as specific functionality hallmarks of the EHR, and also require demonstration of test patients in specific scenarios. And the organization will be tested, I guess, in a way to put it. You will be required to make this presentation on very short notice. The auditor will not allow for this demonstration to take place over a period of days. The expectation is that the staff of your organization will be able to demonstrate it in a very short time and will have familiarity with the CEHRT or the EHR technology. In addition, the on-site audit will include a review of medical and patient records through the EHR, and there will be a review of detailed data to support the summary of reports that supports your attestation. In addition, there will be a review of census reports and billing information and validation of settings of both the capability of the EHR to perform certain functionality, but also demonstration that data can be collected or that specific security measures are in place to support the requirements that audit logs were enabled, that the data integrity can be assured, or that specific requirements regarding access controls have been enabled and are in place. So one of the core measures of the security of meaningful use is to have in place appropriate protections for the electronic health information maintained through the EHR. And in setting this core measure, the core measure specifically refers to the same risk analysis that one would perform to demonstrate compliance with the HIPAA security rule. In addition to performing a security risk analysis, there should be demonstration that there's been implementation of security updates or critical patches as necessary, and that any compliance gaps or security vulnerabilities that are identified through the risk analysis, that they are that there's a schedule for their mitigation or remediation as a part of the organization's regular security or risk management process. The risk analysis can be performed at any time during the annual reporting period for meaningful use, for that attestation period. Unlike other measures which should be drawn or should be documented through a 90-day period of use, the security risk analysis can be performed anytime during the reporting year. The reporting year for hospitals is the same as the federal fiscal year. It begins on October 1st. It ends on September 30th. For eligible professionals, the reporting year is the same as the calendar year. The reports themselves, the attestation reports and the supporting documentation, must be reported within 60 days of that respective period of reporting. So for hospitals, that reporting period, the report period would end on December 1st, and for eligible professionals, the reporting period ends approximately the end of February. So at least once during each attestation reporting period, the hospital or the provider must either conduct another security review or must evaluate the prior review to make sure that it is still valid. And I'm so sorry. And then if the security update must incorporate and account for any deficiencies that were identified during the risk analysis. So in plain terms, that would mean that the core measure requires a constant or annual evaluation and assessment of the information security of your enterprise system. Under stage 2, there are some additional requirements in addition to conducting the security risk analysis. You are required to address the security rule standard, or I'm sorry, the security rule implementation specifications regarding encryption or security of data that is stored in the CEHRT or in end-user devices. CMS has said that this requirement does not expand the requirement of the security rule to require encryption of information that is stored in the EHR or on end-user devices. It does, however, require, as a part of meaningful use, to fully document and explain what encryption technologies have been implemented, and if the organization has chosen not to encrypt, must provide documentation as to the reasoning behind that decision, as well as documentation of compensating controls that would be just as protective of encryption. In addition, there is increased attention under stage 2 to the implementation of updates to the information systems to protect against threats and vulnerabilities, as well as to assure that there is appropriate protections against against intrusion by malware or cyber incidents. We also urge that if you are a professional, healthcare professional, or a hospital that that maintains or transmits information that is subject to the confidentiality requirements of for mental health treatment or substance abuse treatment, that you further review the requirements and consult with the requirements established by SAMHSA for the specific consent requirements under 42 CFR Part 2. So to once again revisit, the security risk analysis is required to be thorough. It's not a checklist approach. It requires a thorough and accurate analysis as set out by the HIPAA security rule to evaluate and to put into place the standards and the implementation specifications to safeguard the confidentiality, integrity, and availability of electronic health information that is held by the covered entity or that is created, maintained, or transmitted by a business associate. So an example of that would be to assure that if you are using a cloud-based EHR service, that they have documented to you that they have the appropriate safeguards in place. In addition, you should include in your documentation the appropriate business associate agreement that would be required to comply with the HIPAA privacy and security rules. CMS has developed a fairly nice suite of documents to help organizations understand their what the requirements are for compliance with the core measure for protecting electronic protected health information. But one of the myths that is widespread through the healthcare sector is that the core measure for security risk analysis only encompasses the EHR, and CMS has been trying to combat that myth, and in fact they have stated on several occasions now that it is the expectation to meet the meaningful use requirement that the security risk analysis must include all of the devices in the enterprise that handle electronic protected health information. And this is what we would, and this is one of the byproducts that we expect to see out of OIG's recent announcement that it is going to conduct independent audits to determine how well CMS is enforcing this provision of the meaningful use requirement. That this is in fact OIG's effort to determine how far or how extensive the adoption of that myth is and how well CMS is doing to combat it. Another point that CMS has made specific reference to is that the deficiencies must be corrected during the reporting period. While the security rule allows for organizations to adopt corrective actions or mitigations that are based on the reasonable resources or reasonably based on the resources of the organization, CMS's view is that if there is a deficiency noted during a reporting period, it must be corrected by the next reporting period. But there is some recognition that the actual timing of the security updates and how they are applied are somewhat driven by the provider's risk management process. I think a reasonable interpretation of this is that if the organization relies on the vendor, the EHR vendor, to provide updates for vulnerabilities identified through its EHR, then the organization has a reasonable period of time to put those updates in place. But it must show a plan to both survey or seek out when updates are available, and a plan for adopting or implementing those updates. Stage 2 has a number of additional measures that must be met. So again, returning to the theme that stage 1 is more of a showing that the EHR has capability of protecting health information and performing certain functions. Stage 2 is the actual adoption or implementation of those capabilities, and some of those, just briefly, go to the ability to perform amendments as requested by individuals seeking correction to their health records, the ability to demonstrate that the EHR can be audited and that there's tamper resistance, that there is end-user device encryption in place for any mobile or removable devices that are associated with the EHR, that there is an appropriate emergency access and contingency planning available that is implemented and tested for scheduled and unscheduled downtime. In the interest of time, I want to make sure I can get to, I see there are a number of questions that there are pending here in this presentation, so I'm going to move ahead and so that we can make sure we can get to them. The audits that are performed by CMS for meaningful use, for the attestation of meaningful use, these are pass-fail audits. That's why it's extremely important that organizations must practice how they prepare for CMS audits. And CMS has been rather open in how they are going to respond to certain instances. So CMS won't penalize a provider for mistakes that are clearly shown through typographical error or other minor errors in the documentation. What is key here is that the organization can quickly recognize and correct when it has made an error. In case that there is a missed core element, either in stage 1 or stage 2, CMS considers this a fatal error, and CMS will seek repayment of all incentive payments that were received in that reporting year, and they will consider that an overpayment. In that case, CMS will provide 30 calendar days for the repayment of the overpayment, but they do provide a right of appeal. The challenge here is that during the appeal process, the interest continues to accrue, and the expectation is that the incentive funds will be returned during the, or in line with the overpayment requirement. In other words, while your appeal is pending, you will have returned the funds that CMS has identified as being received without appropriate documentation. So if your appeal is successful, CMS will once again pay the incentive funds. If the appeal is not successful, the organization will have to, in addition, return the incentive payments as well as any interest and penalties that would accrue on a monthly basis. Even if you are successful in your appeal, you will still be responsible for interest and penalties that will have accrued while the appeal was pending. So, as we mentioned earlier, this has been a highly successful program in which hundreds of thousands of providers and hospitals are participating, and the government has paid out over $25 billion in incentive payments. Politically, this has provided some challenges for CMS in the current environment, and there have been government watchdogs, primarily in the OIG and in the Government Accountability Office, that have reviewed CMS's administration of the Meaningful Use program, and some of those recommendations have forced changes to how CMS administers its program. Some of them have been to require or to institute prepayment audits of attestations as opposed to the original program plan, which all of the audits that were being conducted by Figliosi and Company were in fact post-payment audits. In addition, CMS has been more active in issuing guidance on how to comply with the requirements of the Meaningful Use program, to provide guidance on the specific measures and objectives and how they can be met, as well as the privacy and security core measure requirements. And also as a byproduct of this audit program, they have chosen to remain with Figliosi and Company throughout the audit program because they see a benefit in gaining experience in the auditor's experience and knowledge in the process for reviewing the attestations for meaningful use. And they're also gaining intelligence on how to find data anomalies. So one of the questions that comes up frequently is if I am if I am attesting for meaningful use and after my attestation, I recognize that I've received, that I made a mistake. And so in the attestation documentation or in some aspect of the documentation that underlies the representations made in the attestation. So CMS has issued guidance to providers and hospitals on how to communicate with them regarding errors or mistakes that are made in the attestation process. And there is a toll-free number. It does work. I can tell you that at CynergisTek, we have contacted CMS on behalf of clients or been with clients when they've made these telephone calls. And there is someone, a live person on the end of the phone who answers the call. And this is the first step in creating and correcting an error in the attestation process. I do note that, again, this CMS is administering the Meaningful Use program for the Medicare program. If you are participating in the state Medicaid program, please contact your state Medicaid provider. So one of the other significant concerns is how is a provider or a hospital selected for an audit? What are the key indicators that make an organization more likely or not to be selected for an audit? So CMS in Figliozzi and Company in various conferences and presentations has identified a number of areas that could increase attention or likelihood of an audit, and that is anomalies in the numeric values and in conducting a regression analysis to identify outliers. In addition, there are certain attributes that CMS is using to identify an audit universe or a group of organizations based on size and complexity of the organization. CMS has adopted the approach that they're going to sample through providers and hospitals throughout the universe of size and complexity of organizations. But they're also looking for deviations in the information that is reported in the attestations. They're looking for anomalies off of what they would think is the mean of the group. In addition, they're going to use secondary data sources to compare against attestation data. This is the equivalent of using social media to validate one's status and one's awareness amongst peers. So if an organization is being highlighted in the media as having financial troubles or not, or being a lightly used healthcare facility, and yet their attestation shows emergency department visits that equate to a highly used urban center, that is data that CMS is likely going to pick up on and will be looking to validate. So one of the best tools to prepare for an audit is to assure that you have your documentation in place to support your attestation, to ensure that your data of your populations are validated and are correct, and that that the measures that you are reporting are consistent throughout the attestation period, and that your EHR remains or has the continuing functionality to produce the documentation that's required. A constant evaluation, verification, and audit of the metrics that are being used as the basis for the attestation, as well as to use the actual protocols that are being used by Figliozzi based on the core measures, objectives, and the menu sets, to make sure that if you are selected for an audit, whether it's a desk audit or an on-site audit, that you are able to produce the appropriate documentation or to demonstrate the functionality of your EHR on demand. We would generally recommend that organizations conduct these self-audits or mock audits at least semi-annually, certainly no less than once a year. So with that, I'm going to turn to some of the questions that have been submitted, and so the first question that we have concerns the security risk analysis, and the question asked, is the risk analysis performed for the specific EHR, or is it applied to all other systems as well? CMS has issued guidance and FAQs that were first issued in 2013, and they were recently reissued this past October. They're pretty adamant that that compliance with the core measure requires a security risk analysis of the entire enterprise that handles PHI. This is the significance of the reference in the core measure to the HIPAA security rule requirement. And their view is that they are looking for an organization's compliance with the HIPAA security rule because the EHR is integrated into the information enterprise that handles ePHI. They will be looking for the enterprise-wide risk analysis. The next question is, what defines deficiencies for correction? Deficiencies for correction for purposes of the risk analysis are the threats and vulnerabilities that would be identified through the risk analysis as that should be mitigated, and they can be mitigated by adopting a combination of technical, physical, or administrative controls, or a combination of all three, to reduce the risk posed by the threat or vulnerability. Other deficiencies, as they relate to core measures or the objectives, it would depend on that specific measure or objective, and would encourage that you refer to CMS's guidance on their website for information on how to address those areas. And before I forget, I don't want to leave this program without highly recommending CMS's it's become CMS's website on the Meaningful Use program. It's become much more sophisticated and has really been developed out over time. And the address string is rather long. My recommendation is that you either enter as a Google term CMS Meaningful Use, or you go to the cms.gov website and enter as a search term Meaningful Use Regulations, and you'll be taken to the home page for that website. In addition, another resource is through the Office of National Coordinator, and that remains the website www.healthit.gov, and there is a fairly sophisticated set of materials there regarding electronic health record technology, the Meaningful Use Program, and other activities that ONC is engaged in data security and interoperability. Well, with that, we are at the top of the hour, and I want to thank you for your participation today. Please feel free to send any questions that you may have that may come to you later, or if we weren't able to address them on our call today. My contact information is on the screen, and my email address is david.holtzman, Holtzman, @synergistek.com.